We present the case of a 55-year-old male patient that presented with complaints of vision loss, floaters and photopsia in the left eye over the last 3 days. He was submitted to a 23-gauge vitrectomy the following day. After the core vitrectomy, we confirmed a peripheral detachment with the macula still attached, and in the periphery we could see 2 giant tears, one inferior and another superior and temporal, as well as other tears along the remaining peripheral retina. We proceeded with the appropriate technique for these cases: retinectomy of the anterior flap border of the tears to prevent post-op complications, and retinectomy of the posterior rolled border of the tear. We first cauterized the borders and then cut the rolled tissue with a vitreous cutter in order to make the torn posterior edge more even to better attach it. We then injected perfluorocarbon liquid in order to stabilize and attach the entire retina. Afterwards, we tried to do a careful fluid-air exchange. However, we observed that the retina had slipped posteriorly, and we could not reattach the giant retinal tears. To solve this, we reversed the exchange refilling the eye with BSS and re-injecting PFCL. We applied 3 to 4 rows of endolaser to the entire peripheral retina, particularly to the edges of the retinal tears. We chose to do a direct PFCL silicone oil exchange while trying to aspirate fluid in the PFCL-BFS interface at the edge of both giant tears, a very critical step in these cases. At the end, with the eye filled with silicone oil, we realized that we still could not achieve a complete attachment of the posterior edges of the tears. We saw that the posterior pole had a demarcation line, suggesting that either liquid or silicone oil flowed under the retina. We stopped to consider why this was happening and what to do next. In spite of all these findings, we felt confident that we followed all the appropriate steps of the correct technique for a case such as this one. We decided to end the surgery and concentrate on an early and strict positioning of our patient. First in right lateral decubitus with a flat headboard, and soon after in prone positioning. In the next day, we felt overjoyed when we confirmed that the entire retina was attached and no subretinal changes were observed. As we can confirm on retinography and OCT imaging, after 2 months of follow-up, the anatomical outcome was excellent.